Hi, my name is Sarkis. I'm a nurse practitioner student. I'm going to do a cardiovascular assessment on you. So first I'm going to ask you a couple of questions if that's fine. Okay?
Okay.
Okay. Are you experiencing any chest pain?
No.
Are you experiencing any shortness of breath?
No.
Palpitations?
No.
Okay. Do you have any history of heart attack?
No.
Do you have any history of diabetes?
No.
Do you have any history of rheumatoid arthritis
No.
and lupus?
No.
Okay, thank you. So I'm going to ask you to lay down and put your head over here and your shoulders right there under the pillow. Thank you. So I'm going to position my patient on a 30-degree angle for the head of the bed. And I'm going to, are you comfortable?
No.
See.
Sí.
Are you, so my patient speaks Portuguese. Que se está cómodo, right?
Yes.
So he said yes. Okay, thank you. So I'm gonna, before I saw the patient down, I evaluated this chest cavity. I'm looking for symmetry on both sides. I'm checking the shape of the chest. I look for any lesions, any swelling, any pulsation around the pericardium, which I didn't see any, and any pulsations all over the chest, I didn't see any. So now I'm gonna grab my stethoscope and I'm gonna explain to my patient what I'm about to do. So this is a stethoscope. I'm gonna use it to listen to your lung sounds and your, well, not the lungs, it's the heart sounds and the sounds in your carotid. Okay?
Okay.
So I'm gonna use the diaphragm for high pitched sounds. I'm gonna use the bell for low pitched sounds, and I'm gonna make sure that when I put on the earpiece, it's facing forward towards the ear canal. Okay, so I'm gonna start by inspecting the jugular vein pulse. So what I'm gonna do for that is I already have the patient in the 30-degree angle. I'm gonna have the patient look to the left. So I'm gonna ask you to look to the left. I'm gonna visualize the sternomastoid muscle, and I'm gonna use a tangent light to look for the oscillation point. So if there's a bulging oscillation or no oscillation, I'm gonna have if there's a bulging or no oscillation, I'm gonna reposition the patient. If I can't find it, then I'm gonna use my ruler to measure the jugular vein pressure, and the way I would do that is by placing one ruler in the angle of Louis. So I'm going to find the angle of Louis about 5 centimeters below the sternal notch. So here I'm going to put the ruler perpendicular to this angle of Louis, and then I'm going to use the other ruler to measure from the oscillation point. It should be about no more than 3 centimeters in length. And if it's greater than 3 centimeters, then there's a problem with like fluid shift. It could be congestive heart failure, or the patient, if it's too low, or if I see no oscillation, then I'm worried about dehydration that could be caused by nausea, vomiting, or diarrhea. So that's the first thing I'm going to inspect. And the next thing I'm going to inspect is, well, I already inspected the rest of the chest. So now I'm going to palpate. So I'm going to palpate the carotid pulse. So I'm going to visualize the sternal angle. I'm going to tell my patient to look to the left and right lateral to the sternomastoid muscle. I'm going to push lightly and feel the pulse, and I'm just going to check if I feel for any thrill, which I do not. If I do, maybe there's some turbulent flow. I'm going to do that on the other side. So I'm going to visualize the sternomastoid muscle and check for the pulse and check for any thrill, which I'm feeling. Okay. So the next step is I'm going to check the PMI. PMI is located in the left midclavicular line at the 5th intercostal space. So you would measure from the angle of Louis, which is the second rib. Right under it is the second intercostal space, then the third rib, then the third intercostal space, and the fourth rib, then the fourth intercostal space, and the fifth rib, the fifth intercostal space. So I'm going to palpate the PMI, and I'm gonna check that it's no more than 2.5 centimeters in diameter. And if I can't feel it, I'm gonna ask my patient to turn to the left slightly. So, volteate hacia la izquierda, un poquito. Okay. I'm gonna ask my patient to breathe out and hold it. So, bota el aire y aguanta. Aguanta. And I'm gonna check my PMI. Okay, respira. Okay. Ya te puedes poner. So if my PMI is more towards the axillary line, then I'm worried about conditions like left ventricular hypertrophy. Then the next thing is I'm gonna check the hepatic jugular vein reflux. So I'm gonna have the patient look to the left, I'm gonna again find the jugular vein. I'm gonna I'm gonna tell the patient what I'm about to do. I'm gonna push on the lever so that increases the blood flow to my jugular vein, and then I'm gonna hold that for a few seconds, and then I'm gonna release, and I should see that the blood rushes back into the right atrium. If there's any delay in the outflow, then I'm thinking there's an issue with a fluid retention problem like congestive heart failure. Okay, so voy a empujar aquí. So I'm gonna push on the liver, and then I'm gonna see the rush of blood to the jugular vein. I'm gonna hold that for a few seconds. Tú puedes respirar. And then I'm gonna let go. And that's just, and a normal finding would be that blood flow is going straight back to the heart. Okay, so the next thing I'm gonna do is I'm gonna listen to the heart sounds. Okay, so I'm gonna put this on. So I'm gonna use my diaphragm to listen to the S1 and S2 sounds. The S2 is more audible in the base of the heart, and the S1 is more audible in the apex of the heart. If there's any S3 or S4, I'm gonna use the bell to listen to the S3 and S4. They're gonna be more audible on the left fifth intercostal space. And if I wanna try to improve the sound, I'm gonna have my patient turn to the left, and I'm gonna listen to the fifth intercostal midclavicular space for the S3 and S4. And S3 goes after S2. It's in diastole, and it's usually caused by congestive heart failure. And S4 goes before S1, and it's usually an indicative for hypertension. And also gonna check for murmurs, but first I'm gonna listen to the heart sounds. So I'm gonna put my stethoscope on, and I'm gonna listen to the heart. So I'm gonna find the second intercostal space, right sternal border, and I'm gonna put my diaphragm over it and listen to the aortic valve. Then I'm gonna move to the second intercostal space on the left sternal border, and I'm gonna listen to my pulmonic valve. Then I'm gonna move down to the fourth intercostal space, left sternal border, and I'm gonna listen to my tricuspid valve. And then I'm gonna move to the fifth midclavicular space, and I'm gonna listen to my mitral valve. So again, S2 is louder at the base, and S1 is louder at the apex. I'm also gonna try to check while I'm here the S3 and S4. If the patient has any, I'm gonna put the bell on the fifth midclavicular space on the left side and listen for S3, S4. If I can hear very well, I'm gonna ask the patient to turn to the left. After that, while I do that, I'm gonna also check for murmurs. Two important things to know about murmurs is you have to know where the murmur is. So is it in the second intercostal space on the right or the left? Is it in the fourth intercostal space on the left? Is it in the fifth intercostal space on the left midclavicular line? You also need to know when is it happening. Is it happening in diastole? Is it happening in systole? And then the most common causes would be a mitral valve regurgitation or aortic stenosis. So aortic stenosis you would most likely hear on the right second intercostal space during a systole, and mitral regurgitation, for example, you would hear on the left midclavicular fifth intercostal space during diastole. Okay, so let me think. Back time? No. Okay, so next I'm going to ask my patient to sit up, and we're going to move forward to the peripheral vascular part. So siéntate, Iván. So I'm going to listen to the carotid. So I'm going to have my patient take a deep breath, respira profundo y aguanta, and I'm going to listen at the carotid. Yeah, respira. And I'm gonna do that on the other side too. Respira profundo y aguanta. Okay, breathe. And so I'm checking for any bruit. If there's any bruit, that would be because there's turbulent blood flow. It could be from occlusion or any atherosclerosis, or it could also be from any valvular issues that might be interfering with the carotid blood flow. And then I'm gonna ask my patients a few history questions. So I'm gonna translate for him because he's not gonna understand. So do you have any pain in your legs when you walk? ¿Te da dolor en las piernas cuando caminas?
No.
Okay, do you have swelling on your ankles? Do you have or your legs? ¿Tú tienes alguna inflamación en las piernas?
No.
Okay, and then I'm gonna ask him if he has any lesions or wounds on his legs. ¿Tú tienes alguna herida en las
No.
piernas? No. Okay. So I'm gonna inspect. So I'm gonna look at the arms. So muéstrame los brazos. So I'm gonna look at the collar. I'm gonna make sure that the collar is compatible with his ethnicity, which it is. I'm gonna look at the skin. Is it soft? Is it rough? I'm gonna look if there's any lesions, any swelling, and also gonna look at the nails. For any cyanosis, any clubbing. If I wanted to check for clubbing, I would ask the patient to put 2 fingers, así la uña contra la uña. No, así. Together, and then I'm looking for the diamond shape. I'm also gonna check for the warmth and the skin turgor. Yeah, right. And I'm also looking for symmetry in the muscles. Then I'm going to check for peripheral capillary refill, and the way I would do that is I would push on the finger, and then I should see the pink color come back in less than 2 seconds, which it does, so we'll do that on both arms. I see good capillary refill on both arms. Then I'm going to check the radial pulses. So once I'm and the radial pulse is about 1 inch on the radial side, which is the side of the thumb, on each arm. So I want to make sure that it's within normal limits, which is +2. So it's +2 here, and +2 over here. And then we want to check the brachial pulses, which is next to the groove of the elbow. And then I'm going to do that on the other side. I'm going to make sure it's a +2. If it's lower or higher, I need to check that there's no vascular compromise. Yes. And then we're going to check the legs. So ready to most people come So I'm inspecting the legs and checking for any swelling. For symmetry in the muscles, I'm checking if there's any atrophy. I'm looking for any lesions in our varicose veins in the legs, any venous ulcers or arterial ulcers. I would remove the socks, obviously. Again, swelling, warmth, any hair loss. I would measure the calf muscle, and then looking that they're within 3 centimeters. So I would measure left, and then I would check right, and they're about the same. If there's a difference over 3 centimeters, then I want to make sure that there's no issues with like circulation to the legs. Okay, so then after that, I'm gonna check the pulses. Well, I'm gonna check for swelling first. So for swelling, I'm gonna press down, and if there is a indentation greater than or equal to 2 millimeters, then it's a +1. If it's over 4 millimeters, then it's a +2. If it's over 6 millimeters, it's a +3. If it's over 8 millimeters, or equal to 8 millimeters, same for the other ones, it would be a +4. So I don't see any swelling. And then I would check the pulses, and I would do that first. I'm gonna look for the dorsalis pedis, so it would be, you would follow the tendon of the big toe to like the medial part of the dorsum of the foot, and then you would move laterally, and then you'll check, and then you'll do that on the other side as well. Then I'm gonna check the pulses in the tibia, which I actually feel on this side, and then he has good pulses on both sides. And then for the femoral pulses, I'm not gonna do it, but I would check in the groin. So I would look between the pubis bone and the iliac crest, and then find that groove there and check for the pulses on both sides. And I want to check that they're +2, and if they're less or more than that, then I have to do other exams. I'm also going to check the popliteal pulse. I'm going to have my patient lay down. Right, no, right, down. Con la varillita para abajo. Así. And push. And I feel the pulses +2, very good. Yeah, right there. So after that, the next things I could check is the Trendelenburg leg raise, which I would have the patient lay down, and I would raise the leg. I would place a tourniquet, wait until the leg turns pale. Then I will have my patient stand up. If I should see some pink coming back to the leg then, and then remove the tourniquet. When I remove the tourniquet, I want to see that the color of the leg starts coming back, but slowly. If it comes back too fast or too slow, then I have to check with ultrasound for peripheral vascular disease. And then to check for peripheral arterial disease, I want to measure the systolic blood pressure on the left arm twice, on the right arm twice, on the right ankle twice, and on the left ankle twice. I want to add those two blood pressures together and divide by 2. I'm going to do that with each body part, and then I'm going to do the brachial average on the bottom. I'm going to put the ankle average on the top, and I'm going to divide that. And I'm going to do that for each side, the right with the right and the left with the left. And if the result is greater than 0.90, then it's within normal limits. If it's less than 0.90, then there is a peripheral artery disease. If it's less than 0.39, then there's severe peripheral arterial disease, and then I will refer the patient for further studies. And that's it.